Hey everyone, welcome back to my podcast, Anatomy and Physiology Bit by Bit. This is your host, Dr. Steve Sullivan, coming to you from Bucks County, Pennsylvania, just outside of Philadelphia. I've been teaching anatomy and physiology at Bucks County Community College since 2002. This episode wraps up our coverage of nutrition by discussing vitamin and mineral deficiencies and toxicities. I want to take a quick minute to thank Feedspot.com and MillionPodcasts.com. These websites periodically rank podcasts, and recently they both ranked this podcast the #1 anatomy and physiology podcast. In fact, Million Podcasts also ranked us the #10 biology podcast on the internet. I am sure the reason we rank so high is because listeners like you are gracious enough to rate and review the show. I really appreciate those of you who've done that, and if you haven't, please take a minute to do so. It really helps. I will put a link to those rankings in the show notes so you can see if there are any other shows you might be interested in. Well, I know you're anxious to finish up nutrition, so let's get to it. Okay, let's turn our attention to vitamin and mineral deficiencies. Now that we know the important role played by vitamins and minerals in our normal physiological processes, we can suspect that not having enough of them can be a problem. Specifically, the clinical consequences of inadequate levels of vitamins C, B, A, D, E, and K. Each of these plays a distinct physiological role, and when deficient, they manifest in characteristic ways, many of which have important diagnostic implications in both developed and resource-limited settings. First, vitamin C. Vitamin C is essential for collagen synthesis, wound healing, iron absorption, and immune function. It also acts as an antioxidant, helping to neutralize free radicals and maintain cellular integrity. When vitamin C is deficient, the classic condition that develops is called scurvy. Clinically, scurvy presents with impaired wound healing, bleeding gums, loose teeth, and bruising, petechiae, which is small, flat, pinpoint red or purple spots on the skin caused by minor bleeding from capillaries, ecchymosis, which is the discoloration of skin caused by bleeding underneath, that is from those fragile capillaries, joint pain and swollen limbs due to subperiosteal hemorrhages, fatigue, anemia, and sometimes depression or irritability. Scurvy is rare in industrialized nations, but may still occur in severely malnourished individuals, also elderly people with poor diets, or those with alcoholism or eating disorders. In pediatric cases, it can cause bone pain due to defective osteoid matrix formation. That pain can lead to pseudoparalysis, a condition where there is a loss of active movement in a limb, but it's not because of true neurological paralysis. Instead, it's caused by factors like pain, muscle weakness, or other non-neurological issues. The B vitamins include several distinct molecules, all of which serve as coenzymes in energy metabolism, redox reactions, and biosynthesis. Because they are water-soluble and not stored extensively, they require regular dietary intake. We'll start with B1, thiamine. Deficiency of thiamine leads to a condition called beriberi. That's one word, B-E-R-I, B-E-R-I. There are two kinds of beriberi, categorized by whether or not there is cardiac complications leading to fluid buildup in the limbs. We'll start with wet beriberi. This is the thiamine deficiency that leads to accumulation of lactic acid in the heart, causing it to pump inefficiently. This results in dilated cardiomyopathy, or enlarged heart, edema, which is chronic swelling in the extremities, and tachycardia, a rapid heart rate. Dry beriberi is when the thiamine deficiency damages the nerves, leading to peripheral neuropathies, muscle weakness, and paresthesias like numbness, tingling, and pins and needle sensations. Another critical presentation is Wernicke-Korsakoff syndrome, often seen in chronic alcoholics. Wernicke's encephalopathy presents with the classic triad of ophthalmoplegia, which is weakness in the muscles that move the eye, ataxia, which is a lack of muscle coordination, and confusion. If untreated, it can progress to Korsakoff psychosis, marked by memory deficits and confabulation, which means the person is unintentionally creating memories and stories to fill in the gaps in their actual memories. They're not doing it to deceive anyone. Okay, vitamin B2 or riboflavin. A deficiency in riboflavin manifests with chelosis, which is cracking of the skin of the lips, glossitis, which is a swollen and red/purplish colored tongue, seborrheic dermatitis, which is a common chronic skin condition that causes scaly patches, redness, and stubborn dandruff on your scalp, particularly on oily areas like your face, chest, and, like I said, your scalp. And also photophobia, the intolerance to light, and corneal vascularization, which is an abnormal capillary formation in the cornea. Remember, the cornea should be avascular and clear. Okay, B3 is niacin. A deficiency of niacin causes pellagra, which we use the 3 Ds to remember the symptoms that form the syndrome of pellagra. They are dermatitis, which is a rough skin rash that's actually irritated by light, like ultraviolet light, diarrhea, and dementia. And there's a 4th D, unfortunately, that if this niacin deficiency is untreated, it could lead to death. Pellagra is classically associated with diets that are reliant on untreated corn, which lacks bioavailable niacin. B6 is pyridoxine. Vitamin B6 is crucial for amino acid metabolism and neurotransmitter synthesis. Its deficiency could result in irritability and depression, peripheral neuropathy, glossitis, which we mentioned earlier, and stomatitis, which is inflammation of the mouth's mucous membranes causing painful sores, redness, and swelling. We also get sideroblastic anemia, a group of blood disorders characterized by the body's inability to use iron properly to make hemoglobin, leading to a buildup of iron in red blood cell precursors called sideroblasts. B6 deficiencies could be induced by isoniazid, which is an antibiotic used to treat tuberculosis, hydralazine, which is an antihypertensive medication, and oral contraceptives. Vitamin B9, which is folate, and B12, which is cobalamin, are both involved in DNA synthesis. So their deficiencies lead to megaloblastic anemia, which is an anemia characterized by abnormally large red blood cells. And then you also see a lot of times with megaloblastic anemia, hypersegmented neutrophils, which means that the neutrophils have abnormally high numbers of lobes in their nuclei. In B12 deficiency, there are neurological symptoms like paresthesia, gait disturbances, which means you have difficulty walking, and cognitive changes due to demyelination of the dorsal columns of the spinal cord and the lateral corticospinal tracts. Folate deficiency is common in pregnancy, alcoholism, and methotrexate therapy, which is used in some autoimmune diseases and cancers. B12 deficiencies may result from pernicious anemia, which we talked about in the digestive episodes, which is a lack of intrinsic factor from the stomach's parietal cells. It can also be a result of gastric surgery or even a vegan diet. Vitamin A is critical for vision, epithelial maintenance, immune function, and reproductive health. Its deficiency is especially prevalent in developing countries. Early signs of vitamin A deficiency include night blindness, which we call nyctalopia. That's due to the impaired regeneration of rhodopsin in retinal photoreceptors. Xerophthalmia, which is dryness of the eye's conjunctiva and cornea. Keratin accumulations on the conjunctiva called Bitot signs. And if severe, it can progress to keratomalacia, a softening and degeneration of the cornea, potentially leading to permanent blindness. And there's more to vitamin A deficiency than the eyes. Epithelial tissues elsewhere also suffer, the skin becomes dry and rough, and there is an increased risk of respiratory, urinary, and GI infections due to impaired mucosal immunity. Remember, that mucous membrane is one of our first lines of defense. Children with vitamin A deficiency also experience slowed growth and increased mortality from infectious diseases such as measles. Remember, vitamin D regulates calcium and phosphate homeostasis, promoting bone mineralization and immune modulation. The deficiency of vitamin D leads to rickets, which is a bone-softening condition in children, characterized by bone deformity such as bowed legs and delayed closure of fontanelles. The reason why children get bowed legs with bone softening is because the weight-bearing bones bend as they grow. Sometimes you'll see accumulations of uncalcified cartilage where the ribs meet the costal cartilage. On X-ray, it presents a beaded appearance. It kind of looks like Catholic rosary beads, and they call it rachitic rosary. In adults, vitamin D deficiency causes osteomalacia, a bone softening without deformities. Osteomalacia presents with bone pain, muscle weakness, and increased risk of fractures. Vitamin D deficiency can result from inadequate sun exposure, malabsorption syndromes, diseases that decrease the absorption of nutrients, and chronic kidney disease, where activation of vitamin D is impaired. It's increasingly linked to immune dysfunction, autoimmune disease, and even mood disorders, although these associations are still under investigation. All right, vitamin E, which is a potent lipid-soluble antioxidant that protects membranes from oxidative damage, also has deficiency syndromes, but it's pretty rare that we have vitamin E deficiency. When it does happen, it could usually be associated with fat malabsorption syndromes or cystic fibrosis. And then what will happen is clinically, it'll manifest itself as neuromuscular symptoms like ataxia, loss of proprioception, and peripheral neuropathies. You might see hemolytic anemia in infants due to increased oxidative fragility of red blood cells. So the red blood cells break down before we can actually make more to take their place. And in severe deficiency, we see retinopathy, which is a disease of the retina of the eye, and skeletal myopathy. And the last vitamin we're going to talk about for deficiency is vitamin K. Vitamin K, like we mentioned in the digestive system, is essential for adding a carboxyl group to the glutamate in clotting factors 2, 7, 9, and 10, as well as protein C and S. In episode 40, I explained the process of blood clotting. You can go back and listen to get a fuller understanding of what these clotting factors do. Deficiency of vitamin K impairs the coagulation cascade and presents with easy bruising, prolonged bleeding, petechiae, and hematomas, which are blood collecting outside the circulatory system, elevated prothrombin time, which is basically a measure of how long it takes for blood to clot. Basically, it's an obstruction in the clotting process, and it can lead to abnormal bleeding. It's most commonly seen in newborns whose gut flora haven't yet colonized, hence the routine administration of vitamin K at birth. You see, infants aren't always born with a robust gut microbiome, and that's something I talked about in the digestive episodes. It's those bacteria that produce vitamin K. So to prevent bleeding disorders in newborns, a newborn is often given a vitamin K injection shortly after birth. We also see it in patients on prolonged broad-spectrum antibiotics and those with fat malabsorption syndromes or chronic liver disease. Remember, the lipid-soluble vitamins need to be dissolved in the fat we consume and then absorbed. So if you've got some kind of condition that gets in the way of you absorbing fats in your digestive tract, well, then you're also going to have an issue with deficiency in the lipid-soluble vitamins. Okay, so when it comes to vitamin deficiencies, whether it's C, B, A, D, E, K, they present in distinct but clinically recognizable patterns, often tied to their metabolic functions. We saw examples related to collagen synthesis, energy production, vision, bone integrity, antioxidant defense, and coagulation. A solid understanding of these deficiency syndromes enables clinicians to recognize early warning signs, consider dietary and pharmacological causes, and intervene before complications arise and/or worsen. This is vitally important in primary care, hospital wards, or global health settings. Okay, so what about vitamin toxicity? As we explore the clinical impact of vitamins, it's crucial to understand that not only does their deficiency cause a problem, but also the potential dangers of vitamin excess, particularly when it comes to the fat-soluble vitamins, A, D, E, and K. Unlike water-soluble vitamins, which are readily excreted in the urine, fat or lipid-soluble vitamins are absorbed along with dietary lipids stored in the liver and the adipose tissue, and therefore are prone to accumulation over time. This makes them more likely to reach toxic levels, especially when taken in large supplemental doses. We'll start with vitamin A toxicity. Vitamin A toxicity can occur from chronic overuse of retinoid supplements or high dietary intake, particularly from animal sources like liver. It's important to distinguish preformed vitamin A, which we call retinol, which can be toxic, from provitamin A carotenoids like beta carotene, which the body regulates more effectively. Acute toxicity presents within hours to days and may include nausea, vomiting, headache, dizziness, blurred vision, and muscle incoordination. Whereas chronic toxicity, which develops over weeks to months of high intake, is more insidious and may present with dry, itchy skin and mucous membranes, hair loss, hepatomegaly, which is an enlarged liver, and elevated liver enzymes, bone pain, an increased risk of fractures, and fatigue and irritability. Perhaps most critically, vitamin A is teratogenic. Excess intake during pregnancy, particularly during the first trimester, is associated with congenital malformations, including craniofacial defects, heart abnormalities, and central nervous system malformations. This is why acne medications that are vitamin A derivatives are tightly regulated in women of childbearing age. Vitamin D toxicity almost always results from supplement overuse, because even high dietary intake or sun exposure rarely leads to toxic levels due to the body's feedback regulation of synthesis in the skin. The major danger of excess vitamin D is hypercalcemia due to the increased intestinal calcium absorption and bone resorption. Clinical features include nausea, vomiting, and anorexia, polyuria and polydipsia, that's excessive urine production and thirst, respectively, constipation, muscle weakness, and neuropsychiatric symptoms such as confusion, depression, and in severe cases, coma. In chronic cases of vitamin D toxicity, you might see nephrocalcinosis, a buildup of calcium in the kidneys, kidney stones, and soft tissue calcification in organs like the kidneys, lungs, and blood vessels. Over time, this can progress to renal failure and cardiovascular complications, so careful monitoring is necessary when treating patients with vitamin D supplementation, especially in conditions like osteoporosis or chronic kidney disease. Okay, vitamin E. While vitamin E is less acutely toxic than vitamins A or D, excessive supplementation, particularly in doses far above the recommended daily intake, has been associated with bleeding complications. Vitamin E has anticoagulant properties, and high doses can impair platelet aggregation and interfere with vitamin K-dependent clotting factor synthesis. Signs and symptoms that you might see with vitamin E toxicity is easy bruising, nosebleeds, bleeding gums, increased risk of hemorrhagic stroke, also known as brain bleeds, especially when taken in conjunction with anticoagulants like warfarin. Although vitamin E has been promoted as a general antioxidant, large trials have shown no significant benefit, and in some cases, an increase in all-cause mortality has been seen with high-dose supplementation of vitamin E. So while deficiency is pretty rare, indiscriminate use of vitamin E supplements should be discouraged. And the last one we're going to discuss is vitamin K toxicity. This is also extremely rare. In rare cases of vitamin K toxicity, you might see hemolytic anemia, which we talked about earlier, hyperbilirubinemia, which is excess bilirubin in the blood, and that can lead to jaundice, which is a bilirubin buildup in the skin and sclera of the eyes, causing a yellowish color. In newborns, you might see kernicterus, which is due to the displacement of bilirubin from albumin. But you're probably wondering, what is kernicterus? Well, it's a rare but preventable type of brain damage that can occur in newborns with severe jaundice. It happens when high levels of bilirubin, that yellow pigment in the blood, accumulates and spreads to the brain. It can cause permanent damage. There are three forms of vitamin K, K1, 2, and 3. K1 and 2 are generally safe, even at high intakes, due to the efficient regulation in our bodies. K3, on the other hand, is dangerous. But toxicity is rare because it's been regulated in our supplements in the United States. It's important to note, however, that excessive vitamin K may counteract the effects of anticoagulant drugs like warfarin and other vitamin K antagonists. So interactions should be closely managed in patients who take blood thinners to prevent clotting. So even though vitamins A, D, E, and K are essential for health, their fat-soluble nature means that excess intake can have serious consequences, especially when driven by unregulated supplementation. As clinicians, we need to be vigilant in identifying iatrogenic hypervitaminosis, which means hypervitaminosis caused by a side effect of medical treatment. We also should be educating patients about appropriate dosing and recognizing the signs and symptoms of toxicity, many of which mimic common medical conditions. Careful supplementation based on documented deficiency or risk is appropriate, but more is not always better, especially when it comes to fat-soluble vitamins. In fact, there's a common misconception out there that megavitamin therapy, taking like 10 to 1,000 times the RDA, can boost performance or immune function. But unless you're correcting a specific deficiency, this is not only unnecessary, it can be harmful, especially for the lipid-soluble vitamins. Okay, let's talk about mineral deficiencies now, focusing on 4 of the most clinically significant: calcium, iron, sodium, and potassium. Each of these minerals plays a vital physiological role, and deficiency can lead to distinct and potentially life-threatening clinical presentations. Understanding the underlying pathophysiology will help you recognize early signs in your patients and intervene appropriately.
Bombas makes the most comfortable socks, underwear, and T-shirts.
Warning, Bombas are so absurdly comfortable you may throw out all your other clothes.
Sorry, do we legally have to say that?
No, this is just how I talk, and I really love my Bombas.
They do feel that good. And they do good, too. One item purchased equals one item donated.
To feel good and do good, go to Bombas.com and use code AUDIO for 20% off your first purchase. That's BOMBAS.com and use code AUDIO at checkout.
So let's start with calcium. Calcium deficiency, or hypocalcemia, meaning low blood calcium. As you probably know from previous episodes, calcium is essential for bone and teeth structure, muscle contraction, neurotransmitter release, blood clotting, and second messenger signaling. It is tightly regulated by parathyroid hormone, vitamin D, and calcitonin. When blood calcium falls, commonly due to vitamin D deficiency, hypoparathyroidism, chronic kidney disease, or malabsorption, you get hypocalcemia, which presents with a range of neuromuscular and cardiovascular symptoms. The signs and symptoms you're going to see are neuromuscular excitability due to increased sodium permeability of neurons, so paresthesias, especially around the mouth and extremities, tetany, which is muscle cramps, hand and foot spasms, and laryngospasms in your throat in severe cases. Facial muscle twitching when tapping over the facial nerve, and Trousseau's sign, which is a carpal spasm induced by inflating a blood pressure cuff. You might also see seizures due to increased neuronal firing, and cardiac arrhythmias, especially a prolonged QT interval. As we discussed with vitamin D, long-term calcium deficiency in children can lead to rickets, and in adults to osteomalacia and secondary hyperparathyroidism. In postmenopausal women, chronic low calcium intake contributes to osteoporosis and fracture risk. The next one we'll talk about is iron. Iron is a critical component of hemoglobin, myoglobin, and various cytochromes involved in the oxidative phosphorylation processes. The body's only significant loss of iron occurs through bleeding, since there is no regulated excretory pathway of iron. Iron deficiency is the most common nutritional deficiency in the world, particularly affecting infants, women of reproductive age, and individuals with chronic blood loss, like gastrointestinal bleeding from ulcers or heavy menstruation. The signs and symptoms you'll see with iron deficiency is fatigue, weakness, and pale skin, dyspnea, which is difficulty breathing, heart palpitations, pica, which is the craving for non-nutritive substances like ice, dirt, or starch, glossitis, angular cheilitis, which is lip crackings in the corners, koilonychia, which are spoon-shaped fingernails. And in children, you might have impaired cognitive development and behavioral disturbances. So since iron is a main component of hemoglobin, the part of hemoglobin that binds oxygen, an iron deficiency is an anemia. It decreases our ability to carry oxygen through our bloodstream. So iron deficiency anemia, which is the most common anemia, is classically microcytic, which means the red blood cells are small, and hypochromic, meaning that they also have less of a red color. In any adult male or postmenopausal female with iron deficiency, gastrointestinal malignancy or chronic bleeding must be ruled out. Okay, hyponatremia or sodium deficiency. Remember that the chemical symbol for sodium is Na. That is a Latin term, natrium. So hyponatremia is low sodium in the blood. Sodium is the principal extracellular cation, or positive ion, and is vital for maintaining plasma osmolality, blood pressure, and nerve conduction. And is vital for maintaining plasma osmolality, blood pressure, and nerve conduction. Blood levels of sodium reflect the water balance more than the total body sodium content. So we might get hyponatremia from excessive free water, diuretics, adrenal insufficiency, or heart, liver, or renal failure. Clinical manifestations of hyponatremia depend on severity and rate of onset. We have some mild to moderate symptoms like nausea, headache, and confusion, and then some severe or very rapid onset symptoms like seizures, coma, cerebral edema due to osmotic water influx into brain cells, and death, especially if sodium levels go below 120 milliequivalents per liter. Chronic hyponatremia may be well tolerated due to cerebral adaptation, but rapid correction, especially with hypertonic saline, can cause osmotic demyelination syndrome, also known as central pontine myelinolysis. This presents with joint dysfunction, difficulty swallowing, paralysis, and altered mental state. And the last deficiency we'll talk about for minerals is potassium, hypokalemia. Remember, K is the chemical symbol for potassium. Potassium is the major intracellular cation, crucial for maintaining resting membrane potential, muscle function, and cardiac electrical stability. We can get hypokalemia from vomiting and diarrhea, excessive urination, which could be from diuretic use or having too much aldosterone in your body. Insulin therapy or alkalosis. Alkalosis is when the blood plasma pH gets too high or becomes too alkaline. And an inadequate dietary intake of potassium, which is pretty rare because there's plenty of sources in our foods. The signs and symptoms we typically see with hypokalemia are muscle weakness, cramping, and in severe cases, paralysis. Ileus, which means your intestine can't properly propel its contents distally, and this is due to impaired smooth muscle function, cardiac arrhythmias, and rhabdomyolysis. And that's actually pretty rare, but that's the breakdown of muscle tissue, and then that broken down muscle tissue releases its components into the blood. Chronic hypokalemia can lead to renal concentrating defects, nephropathy, which is kidney disease, and glucose intolerance. All right. As you might expect, you can have too much of these minerals as well. Excesses of calcium, iron, sodium, and potassium, typically resulting from underlying disease, a side effect of medical treatment, or toxic exposures, can lead to serious and sometimes life-threatening complications. So let's talk about the excesses of minerals. Hypercalcemia, which is calcium toxicity, calcium levels are too high, can often result from primary hyperparathyroidism. Too much parathyroid hormone is breaking your bones down and releasing the minerals into your blood, or a malignancy, specifically squamous cell carcinomas or bone metastases. You also might get it from vitamin D toxicity or diseases like sarcoidosis, or you can get it from too many diuretic medications. Calcium raises the threshold for depolarization, resulting in depressed neuromuscular excitability. When you think about the signs and symptoms of hypercalcemia, we use the mnemonic stones, bones, groans, thrones, and psychiatric overtones. So we get kidney stones, we get bone pain from excessive bone resorption, we get groans, that's abdominal pain, constipation, nausea, pancreatitis, peptic ulcers. So we get the groans is basically because you're in pain. Thrones refers to polyuria and dehydration. due to nephrogenic diabetes insipidus. Diabetes insipidus is a condition characterized by an inability to regulate fluid balance due to low levels of antidiuretic hormone. You might remember from episode 35 that antidiuretic hormone, or ADH, is synthesized by the hypothalamus but stored and released by the posterior lobe of the pituitary gland. ADH stimulates the kidneys to reabsorb more water, decreasing urine volume. When ADH is low, we see excessive urination resulting in dehydration, and then we respond with excessive thirst and water intake to compensate. These are similar symptoms as diabetes mellitus, but unlike mellitus, insipidus is not due to glucose intolerance, so there's no glucose in the urine. The word mellitus is Latin for sweet or honey-like, since the urine has sugar in it, whereas insipidus is Latin for tasteless, because the urine has no sugar. Now brace yourselves for this. The reason these terms exist is because up until the early 20th century, practitioners tasted patients' urine to diagnose diabetes. The urine test strips that we see today that can detect glucose, protein, bacteria, and other contaminants weren't invented until the 1940s. So be glad you're studying medicine today. Thrown means you're sitting on the toilet a lot because you're peeing all the time. And then psychiatric overtones, fatigue, depression, confusion, and in severe cases, psychosis or coma. Hypercalcemia can also affect your heart. You can get shortened QT intervals on ECG and an increased risk of arrhythmias. Okay, unregulated excess of iron is also toxic, especially because the body has no efficient way to excrete it. Excessive iron leads to free radical formation, which can damage lipids, proteins, and DNA. There are two main contexts for iron toxicity. Acute iron poisoning, most often in children who take a bunch of iron supplements, like they think it's candy or something, so they take a bunch of iron pills that are in their house. And chronic iron overload, as seen in hereditary hemochromatosis or repeated transfusions. The acute toxicity for iron, which usually means greater than 60 milligrams per kilogram of body weight of elemental iron, usually sees initial gastrointestinal symptoms like vomiting, abdominal pain, and bloody diarrhea, followed by the latent phase. So you go about 6 to 24 hours where the symptoms seem to resolve, and then sudden deterioration, metabolic acidosis, shock, hepatic failure, that's liver failure, bleeding, and death. Iron pills may appear as radio-opaque densities on abdominal x-ray, so they can take an x-ray and see all the pills in your digestive tract. Because iron's a metal and it blocks x-rays. Chronic iron overload leads to cirrhosis of the liver, cardiomyopathy, which is a disease of the heart muscle, diabetes mellitus, arthropathy or joint disease, and hypogonadism. So due to the pituitary iron deposition, you get atrophy of the ovaries and testes. If you have too much sodium, which is hypernatremia, you can have issues as well. It typically is a result of water loss exceeding sodium ion loss. So you lose too much water and your concentration of sodium goes up. So it's not really about ingesting too much sodium. So we see it in dehydration, diabetes insipidus, osmotic diuresis, and medical sodium administration. Because sodium is the main extracellular ion, hypernatremia creates a hyperosmolar state. That draws water out of cells, leading to cellular dehydration, which is most notably affecting the brain. The symptoms that you'll see are thirst, irritability, confusion, seizures, focal neurological deficits, coma, muscle twitching or rigidity, or intracranial hemorrhage due to brain cell shrinkage, and then veins rupture. And finally, lethargy, which is a feeling of fatigue, lack of energy and motivation, and sluggishness. Think of the word lethargic, which is the adjective form of lethargy. Hypernatremia must be corrected carefully. Too rapid a drop in sodium can cause cerebral edema and herniation. Aim for a gradual correction, generally not exceeding 10 to 12 milliequivalents per liter per 24 hours. And then finally, potassium. Hyperkalemia is potassium excess, too much potassium in the blood. This is a medical emergency because it has profound effects on cardiac conduction and muscle excitability. The causes of hyperkalemia include renal failure, that's kidney failure, that's the most common cause. Cell lysis, cells break down. Acidosis, which drives potassium out of the cells. And a side effect of medications like ACE inhibitors, potassium-sparing diuretics, NSAIDs, nonsteroidal anti-inflammatory drugs like ibuprofen and aspirin, or excessive supplementation of potassium. Typically, we'll see neuromuscular symptoms like weakness, paresthesias, ascending paralysis, which is rare and means muscle weakness or paralysis that begins in the lower limbs and progresses upward through the body, cardiac changes, progressive ECG changes, peaked T waves, widened QRS complexes, PR prolongation, loss of P waves. Severe hyperkalemia can be rapidly fatal if not treated, and if it does need to be treated, you need to stabilize the heart, you need to shift potassium intracellularly, and you need to remove potassium from the body.
You buy a pair of socks, that's 2 socks. You buy a pair of Bombas socks, that's 4 socks. Because one purchased is one donated. Socks are the #1 most requested clothing item in homeless shelters. So when you buy a pair of super comfortable Bombas socks, you're also donating a pair. Bombas customers have powered over 150 million donations. So Bombas would like to thank you 150 million times. But we only have like 30 seconds. Go to bombas.com and use code AUDIO for 20% off your first purchase. That's BOMBAS.com and use code AUDIO at checkout.
Okay, to sum up minerals and vitamins, although they're required in small quantities, they are absolutely vital to human physiology. They serve as cofactors, coenzymes, osmotic regulators, and antioxidants. They play roles in everything from electrolyte balance and metabolism to hormone production and gene expression. As clinicians, you need to understand that not only do they have biological functions, but also you have to consider their sources, their deficiency syndromes, and toxicity risks. It is essential in both preventive medicine and clinical nutrition to understand the biological functions of vitamins and minerals and how people are going to get them, what happens if they don't have enough, and what happens if they have too much. Well, everyone, that wraps up nutrition. Now that we know about all the macro and micronutrients we need to consume in our diet, we can spend the next 2 or 3 episodes on how we metabolize them and what we use them for specifically. Once again, thanks for listening. I hope this show is helping you get your B or better in A&P. Good luck, and I'll talk to you next time.